Morning, everyone. Mark Crowther, Chair of the Department of Medicine. I'm just going to give people a few minutes to fold in because it takes a minute for Zoom to bring people into the thing, and then we'll get started with grand rounds. Thank you for joining us. So probably about 30 seconds or so, we'll get started. So just give us a few minutes. Morning, everyone. We'll get started in just a second. I'm just giving Zoom a chance to get everybody folded into the meeting, so I'll just take a second to do that. Just another couple of seconds while I wait for the Zoom numbers to stabilize. We're still accumulating people. Okay, we'll get started. Welcome, everybody. Mark Crowther, Chair of the Department. This is Chair's Grand Rounds, and we welcome you all to them. Just a quick business note. You will hopefully have received an email about a social event for the department on April the 8th at the Canadian Warplane Heritage Museum. If you are wishing to attend that, you need to sign up quickly because we're approaching our limit, which is 500 people. We were at just over 400 yesterday. It's the Department of Medicine plus the wider faculty. So Dr. MacKillop, who I'm going to introduce in a second, should have received an invite to that, I hope, and has signed up for it. Additionally, during the course of the webinar today, we do have the chat function and the question and answers activated, which is unusual. I usually turn off the chat function, but I've been asked to have it on by some attendees. So please keep an eye on the question and answers as they fly by. If you do need to have a question, I'd prefer you ask it in the question and answer function. It's a lot easier for us to track than if it's in the chat function, because the chat functions do tend to accumulate fairly quickly. The grand rounds today is our monthly medical grand rounds, and starting next week again, we'll have the local grand rounds for Hamilton Health Sciences at St. Joe's. So our speakers today, I'll just introduce really quickly are Dr. James MacKillop, who's a psychologist in the Department of Psychiatry, and who has an enormous research profile in addictions medicine. We recruited James here probably close to a decade ago, I would think now, right? Approximately. And he's led an enormous development of addictions medicine research and imaging here at McMaster University, and has really established McMaster as a center for this. Dr. Leslie Martin, who is our program director in internal medicine, as we all know, and has also been working on an addictions medicine service for a very long time and has recently seen a lot of success in that area. And Dr. Tim O'Shea, I think probably everybody knows in the department, is an infectious diseases physician up at the Juravinski, and who is prominently featured in the Hamilton Spectator on a regular basis for the enormous amount of good work that he's doing in Hamilton's disadvantaged community. So without further ado, I will turn it over to our speakers, and thank you very much.
Thanks so much, Mark. It's great to be with you today. I'm going to be sort of emceeing a little bit. It's my pleasure to tell you a bit about a number of different research initiatives that have been happening. It's less a series of studies or a single line of inquiry. What we'll be describing today is a kind of federation of research initiatives that have been happening for a while in Hamilton at the Peter Boris Center for Addictions Research, at the HamSmart research program, and also in inpatient addiction medicine. And they all sort of have the common DNA of doing research in active clinical services and developing platforms for doing research in the community where patients are being seen. So just to kind of give you an overview, I'll give a very brief introduction to just the relevance of substance use disorders across medical subspecialties. I'll tell you a bit about the Peter Boris Center in particular and our emphasis, in addition to traditional or conventional clinical research, to integrative clinical research, and offer you a couple of examples of what we're doing at St. Joseph's Healthcare Hamilton and at Homewood Health's addiction medicine program. Then I'm going to turn it over to Leslie, who will tell you a bit about some of the data that have been collected at the joint St. Joe's and Hamilton Health Sciences Inpatient Addiction Medicine Service. And then Tim will tell you a bit about some of the HamSmart research initiatives, all of which have this common through line of really trying to meet the challenges of substance use disorders currently by doing research in applied real world settings. So to get started, fundamentally, I want to start with the fact that often people underappreciate that substance use disorders are actually the most common psychiatric condition. They are almost double the rate of the second most common condition, mood disorders. That includes alcohol use disorder, tobacco use disorder, stimulant use disorder, and does not include other addictive behaviors like gambling disorder or compulsive eating as expressed by binge eating disorder. This is the lifetime prevalence. About 1 in 5 Canadians will at some point develop a substance use disorder. If you look at the 12-month prevalence, the numbers are similar. About 1 in 10 individuals will meet criteria for a substance use disorder compared to the two most commonly other conditions, mood disorders or anxiety disorders. So these are really the most common mental health conditions that exist. But they really are relevant in medicine beyond just psychiatry. In terms of thinking about the morbidity and mortality of substance use disorders, in addition to being psychiatric conditions unto themselves, they contribute substantially to a variety of acute forms of morbidity and mortality. That includes accidental injury and death, violence, and also infectious disease transmission. This is particularly the case for illicit substance use disorders and alcohol use disorder. They're also major contributors to chronic diseases, cancer, cardiovascular disease, lung disease, and liver disease. This tends to be predominantly tobacco use disorder and alcohol use disorder. But fundamentally, these conditions are major upstream contributors to the downstream conditions that are being treated across medical subspecialties. So one of the reasons that this work is emerging is because of the relevance of addiction, not just in psychiatry, but across medicine, and the need for its clinical management and for education in this area. So to tell you a bit about the work that we're doing at the Peter Boris Center, there are really 4 foci: experimental behavioral science, clinical research, which I'll talk more about in a second, taking the behavioral paradigms we study in the lab and unpacking them using brain imaging, using cognitive neuroscience, and then examining genetic variation as a source for the variation we see in behavior, in brain, and in clinical outcomes, but also using those different domains as ways of understanding the substantial genetic contributions to addiction. So there's a broad array of research that's happening at the Peter Boris Center, generally falling into these 4 foci. To give you a little bit more detail, a lot of our brain imaging research is taking place at St. Joe's Imaging Research Center, but also in other settings. We do most of our behavioral science at the center itself in neutral spaces, but also we have a bar laboratory where we can study things like the role of alcohol cues on behavior, or how medications affect people's reactions to alcohol at varying levels of the blood alcohol curve. So experimental human psychopharmacology research. And then the clinical research that we're doing is primarily at St. Joe's, at the hospital-based programs like the outpatient concurrent disorders program, some of the Charlton units, but also in the community at Womankind and Men's Addiction Service Hamilton. We're also embedded at the Addiction Medicine Service at Homewood Health Center, and I'll present some of those data later today. So the scope of the research program is really trying to range from extremely controlled environments using primarily biomedical techniques like at the IRC, all the way out to real world settings at our clinical addiction programs. A distinction I want to make is that we do both conventional clinical research and what I would describe as integrative or real world clinical research. And there's a real distinction between the two. Conventional clinical research tends to involve randomized controlled trials using experimental designs in which you have one or more experimental groups compared to comparator groups, often involving a placebo of some sort. Conventional clinical research tends to have pretty strict eligibility criteria for who can be included or who should be excluded. The interventions tend to be relatively homogeneous. The generalizability is to patients with the conditions, but are not necessarily to broader, more complex or heterogeneous conditions, patients. And the stakeholders tend to be primarily researchers in the academic community. Integrative clinical research is intentionally using observational designs in actual clinical settings in which there are no eligibility criteria. If you're being seen in the program, then you're eligible to be in the study. There's an emphasis on high complexity and comorbidity as a strength of the research design by virtue of capturing real-world patients. The generalizability is self-evident to the extent that it applies directly to the program that is generating the data, and also to other programs that are similar in the clinical community. And the goal of integrative clinical research is to engage patients, programs, and research stakeholders all simultaneously. So there's a benefit for all three, not just to the research community. So what this often looks like is trying to implement universal assessments that can serve essentially three masters, for lack of a better word. And this notion of universal structured screening and increasingly follow-up assessments too. And by using the same assessments consistently across programs, they can contribute to clinical care by generating data that can be fed back to clinicians in terms of information about patients to improve diagnostic dispositions, to monitor risk, and to contribute to measurement-based care. They can also contribute to program level outcomes by providing data that can be used for quality improvement or program evaluation. They can give a program a sense for what the characteristics of the program patients look like, to look at changes over time and to identify programming needs in terms of developing novel strategies. And ultimately, by pairing these assessments with HiREB approved protocols, we can also collect data that can be used for empirical research. And this can include studies that look at psychometric validation, implementations of measurement-based care, or changes in outcomes using observational designs. And these all fall very much on different timescales, but the idea is that the same data point can really serve three different outcomes in terms of patients, programs, and researchers. So just to give you a sense for what this looks like in practice, this is an example of a patient report from one of our embedded integrative clinical research programs. This is from the St. Joe's Young Adult Substance Use Program. And so patients at admission are screened using a variety of different research grade validated measures. And those data are piped into a data sheet for every patient. And although the fields here are pretty small, what you can see is that this is basically a hockey card or a baseball card that gives you a snapshot of what the patient's profile looks like. Their demographics, their substance use profile, where they're screening positive across a variety of different psychiatric screens, if they're exhibiting self-harm characteristics, whether they have a history of head injury, whether they're smoking or gambling in terms of substance use and addictive behavior that tends to fall outside the program's priorities. So this is data collected from every patient that can be fed back to the clinicians as they do their admission intake and can help prioritizing different groups and specific strategies within the program's one-on-one care. At the program level, these data can also be used to create reports. So this is a monthly report for the withdrawal management stream at Womankind. So those same data can be, again, piped into a standardized report that gives us a sense for January 2022, what the level of alcohol severity looked like, the drug use severity, what the most common psychiatric comorbidities were, the prevalence of those, whether or not individuals were also reporting gambling, smoking, or other characteristics like head injury. Unfortunately, we see extremely high rates of head injury in our populations, and the extent to which we're seeing suicidal ideation. So again, each month, the program gets this snapshot of what's happening in terms of the patients who were admitted over the course of that month to inform programming changes and respond to emerging issues. In terms of how these data can be used for research purposes, we do what can be thought of as a form of precision medicine by basically phenotyping clinical populations to identify common clusters of patients that might benefit from different care paths. So if we think of on the far left, standard care being for a group of patients that are quite heterogeneous in nature, precision medicine fundamentally using many different biomarkers or behavioral markers tries to then classify individuals into more homogeneous subgroups and provide specific customized care for those subgroups. So it's kind of moving from a one-size-fits-all strategy to a which-size-fits-best strategy. And in this case, what we've been doing is collecting data from different clinical programs and then using latent profile analysis to basically identify the clusters that exist within those programs. And I'll just give you an example from the Homewood Addiction Medicine program. We did an initial study in which we did a latent profile analysis on about 1,100 patients in the Homewood program. At the bottom of your screen, you can see the 5 different indicators we looked at: alcohol severity, drug severity, depression, anxiety, and PTSD. And this is basically a factor analysis of people rather than items. And what we found was that there were 4 different clusters of patients. There was one cluster that was high in alcohol, but low in everything else. There was a second cluster that was high in drug severity, but low in everything else. There was one cluster that was high in alcohol, but had a lot of psychiatric comorbidity and did not have high other substance use disorder severity. And then finally, there was a group that was low in alcohol severity, but high in other drug use disorder severity and high psychiatric comorbidities. So 4 very different profiles. We then applied this approach in a second replication cohort of about 800 subsequent patients. And what we found were the exact same profiles using confirmatory latent profile analysis. So basically uncomplicated alcohol use disorder without psychiatric comorbidities, uncomplicated other substance use disorder without psychiatric comorbidities, and then high alcohol and high other drug with psychiatric comorbidities. What's really important about these profiles is that they mapped onto a number of important outcomes. So for example, the prognosis was quite different. People who had uncomplicated alcohol use disorder completed the program successfully significantly more often than the other 3 groups. In contrast, the group that had high drug use severity and also high psychiatric comorbidities showed significantly reduced success in completing the program. And that's one of the earliest prognostic factors in terms of long-term recovery. We also found that there were differential clinical factors. So 2 clusters showed significantly greater cravings, significantly greater impulsivity. And these are the actual results. You can see that there's a gradient of difference across these clinical outcomes. And that suggests that there are meaningful differences in addition to just the symptom presentations. And what this is providing now in the next phase of this work is basically a research-based focus for how we can develop care paths for these 4 different clusters of patients that keep coming up now in nearly 2,000 patients in the Homewood program. So this is an example of how one set of assessments can feed data back in near real time to improve care, can feed data back in the intermediate time frame to improve programming, and ultimately can contribute to research by producing meaningful findings across large numbers of patients that can inform ultimately how programs may choose to develop different care paths for their latent profiles. So let me stop there. I'm going to turn it over to Leslie, who will tell you a bit about the Inpatient Addiction Medicine Service.
Thanks, James. So many of you are familiar with our service, and we were established in 2018. And unfortunately, right off the hop, we did not think about starting to evaluate our outcomes and evaluate our service. But in working with Dr. MacKillop and the team at PBCAR, we've been able to do that, and we were able to start in 2020. James, you can go to the next slide. And we spent a long time really trying to establish what best outcomes we should be looking at in this real world population, recognizing the limitations of retrospective data. And in particular, many outcomes that we would traditionally think about, such as length of stay, if we're doing a good job, in fact, could get worse or prolong length of stay based on our interventions and making hopefully the hospital a little bit more of a palatable place for people to remain when they have substance use disorders. So we landed on, obviously we have been collecting significant amounts of demographic data, but we've also landed on outcomes, including readmission to hospital, discharges against medical advice or unplanned discharges, and reasons for that as best captured in the retrospective data, connection to services at discharge, whether, as best we can tell, they were able to achieve a therapeutic opioid agonist therapy dose, such as methadone or Suboxone, and then mortality. You can go to the next slide. So we're still quite early on in this data. As I said, we started to collect in 2020, and we've been really playing catch up for the majority of this time, and we're partway through our 2021 data cohort. So you can see an increase in the number of consults that we've been seeing as our service has expanded, and we've been capturing both unique admissions and then readmissions. I'm not going to spend time focusing on our demographic data just because of time, but I thought it would be helpful to talk through some of those outcomes and how we've been looking at those and how we've been able to use them to inform care pathways and changes to our service delivery, which I think is a nice harmony to what James has presented. So if we look at our patient-initiated discharges, we're sitting at around 18%. And if you look at other studies, about 20% would be the average for this patient population. Going into this, we had a little bit of an expectation that some of these would be happening after hours and overnight, but in fact, we do see that the greater proportion of these occur in the daytime, which I think is helpful information to know when we're trying to think about how do we reduce or at least plan better for AMA discharges. We aren't sure the rationale from this retrospective cohort for about 50% of the patient-initiated discharges, but withdrawal and cravings are about 25%, which I don't think comes as a surprise, nor does it come as a surprise that challenges either amongst the team or with the institution leads to about the other 25%. You can go to the next slide. Following up on that withdrawal and cravings piece, based on our data set, approximately 60% of patients seem to reach a therapeutic dose of methadone and about 45% a therapeutic dose of Suboxone. So only, not ideal when we're thinking about trying to target both withdrawal and cravings, both to meet our patient needs, but also to reduce the chance of unplanned discharges. Discharge location has become another highlight for a future target, and it's been actually quite helpful that we can feed forward some of this information. So about 25% of the patients that we've seen over the past 3.5 years that we've captured data are being discharged to unstable housing. So that includes no fixed location, precarious housing such as couch surfing, or shelter beds. So this is an area that certainly we've been advocating around. You can go to the next slide. And in fact, Tim will speak shortly about the transitional beds program, but recently I was able to feed forward some of this data around a call for more transitional bed programs, as well as a predicted potential need based on the data that we've seen. Another opportunity with this data is to look at some of our highest risk patients through readmissions. So you can see the majority of our patients, we know this patient population is at high risk for readmission, and the majority of our patients might have one readmission. However, there's a subset of our patients that have 5 or more readmissions. It's a small piece, but we know that these patients are probably the most complicated, the most high risk. Probably have more negative outcomes, and that certainly could lend itself to looking at other interventions or pathways, as James had mentioned, where we can really be looking at this high-risk group. And that is not work we've done yet, but it's something that this data has really raised as something we should be doing. It's also been very helpful to inform other work. So many of you might be familiar with the Second Heart program, which is a research program funded by a HASO grant led by my colleague, Dr. Robin Lennox, as well as Drs. Rich Whitlock and Emily Bellicote. And what we had seen is that the enrollment numbers had been lower than we anticipated when we first designed this study. So we were able to use our retrospective data cohort to look at how many patients has our service seen with infective endocarditis, because this is an intervention looking at patients with both substance use disorder and infective endocarditis. And the original inclusion criteria was that you had to be Hamilton-based to qualify for the study. And so what we found is that 40% of the patients that we were seeing through our service with infective endocarditis were actually transferred from a regional hospital. So they would have been excluded from study inclusion based on that fact alone. And then a subset had also left AMA, which would certainly be a barrier to enrolling them in the study. So this has been helpful to inform conversations around whether we need to broaden those inclusion criteria and seek partners in some of our regional areas in order to increase the footprint and impact of this intervention. So we recognize that there's limitations to retrospective data. It's only as good as what is documented. And one of the biggest shortcomings is that we really haven't been able to capture patient-important outcomes. So we can infer from the chart that somebody left because of cravings and withdrawal based on what was documented, but we don't really know what that patient is experiencing. We don't really understand the impact of our service in the data on their motivation or engagement, or the impact on the hospital experience. So that led us to the next arm of our study, which is our prospective study that was started in October. You can go to the next slide. And this is just our team highlighted here, and this work would not be possible without our fantastic team or the support of Peter Boris. So I just wanted to recognize everyone. So this study is entitled the PRAISE study, and we've rolled this out specifically at St. Joseph's because it's quite intensive. Our research assistants need to meet with the patients, and so multi-site wasn't feasible for the first stage of this. You can go to the next slide. So we began our recruitment in October, and we're doing quite well up until December, and then it had to be placed on pause in the setting of the Omicron wave and reduced ability for research assistants to enter St. Joseph's premises. But we've been able to resume it as of last week. So I recognize the numbers right now are quite small, but we did want to present some preliminary findings. So we've enrolled 13 patients and 9 completed the discharge session. Unfortunately, sometimes discharges happen quite quickly, and we weren't always able to capture the discharge session. So this is just a little snapshot of some of the data that we've been able to capture. I haven't shown all of the different substance use disorders that we're measuring, but you can see that we're dealing with a very severe opioid use disorder population, and this is by DSM criteria that they're filling out during the real-time survey. And you can also see that our patient population, a smaller fraction are using stimulants, but those that are, a good proportion have severe stimulant use disorder. In the bottom table under the pie charts, you can see that we've been measuring motivation to change across scales. And it's quite exciting to see that our patients are expressing a significant readiness to change at about 90%, recognizing significant importance, 100% across the board for opioids. And the confidence is really somewhere where it might be a place that we can continue to work. And our plan is to measure all of these both at an entry point to our program as well as at discharge and then upon readmission. We're similarly screening for some of the high-risk mental health comorbidities that James had mentioned, including anxiety with the GAD-7, traumatic brain injury, as well as depression with PHQ-9. And we are seeing in our small subset of patients high comorbidity at this stage. We will be measuring services that patients receive in hospital. Again, these numbers remain low, but a large proportion thus far of the patients captured are receiving methadone for their opioid agonist therapy. And we're also asking about substances that patients are using while in hospital. And so one of our 9 completed discharge summaries thus far endorse ongoing substance use while in hospital. And thus far of those that we've captured, 4 are reporting ongoing cravings with a mean severity of 4.3 out of 10, and 4 were reporting ongoing withdrawal with a mean severity of 5.75. So again, this is a really important marker that we know from our other data sets are going to increase the risk of unplanned discharges. And so if we can continue to see improvement in this, then it's a marker both of program success and a really big impact on a patient-important outcome. One of the most important parts of this study is that we wanted to understand the feasibility of this, and a lot of thought went into the questionnaire design. We're very concerned that it might be quite burdensome for patients to fill this out. Certainly around enrollment, we've been able to capture about 40% of potential patients. And so we do recognize that because sometimes of short stays in hospital or people being quite unwell, that we are only going to be able to capture a subset of patients, and we've been tracking the percentage of enrollment that we've been able to achieve. In terms of the honesty of the answers, we weren't sure if patients would feel comfortable sharing their responses because of trust around the hospital environment. But in fact, those that have answered have shared that they've answered as honestly as they could, about 92 to 100% of the time. We were worried about the impact of this and whether people would be willing to participate or recommend to a friend. And actually, in fact, 100% of our participants said that they would recommend that a friend participate. And they did feel that our incentive, which was a $10 Tim Hortons gift card, was appropriate, and we'll continue to monitor these feasibility metrics. We also are working to capture patient perspectives. And I think, many of these are quite exciting to see. So almost 90% of our patients agreed that they would come back to St. Joseph's Hospital. They felt that their needs and values were respected, and they felt that they were supported in their recovery. Only 33% agreed or strongly agreed that they were involved in the discharge plan. So I think that's another important place that we can target program improvement. And about 22% considered leaving AMA, which reflects, in fact, our approximate AMA discharge rates from our retrospective data. And so that's also something that we're going to continue to monitor and try to intervene upon. So this prospective data collection is quite early days, but we're very excited that it will be very powerful data to inform our understanding of our patients' experience, to track these patient-important outcomes in a way that we weren't able to with our retrospective data set, and to really further guide program improvement and the development of care pathways. We do have care pathways underway with admission of pregnancy patients, and I didn't present that data, but we'll also be following that patient population. And to track the impact of our QI initiatives by watching these AMA discharge rates over time across both our retrospective and prospective data sets. I just want to also say that I'm very grateful to our patients, our care providers, our interprofessional team, and the support of the PBCAR team to make this happen. Thanks so much, and I'll pass over to Tim.
Good morning. Yeah, so I'm going to pick it up from there. So I'm going to talk a little bit about some two projects that are associated with the HamSmart team and as well with the Peter Boris Center, similarly looking at patients with complex mental health needs and substance use disorders. Next slide, please. So the two current relevant studies to this talk are one that is an OHTN, Ontario HIV Treatment Network funded evaluation of an HIV treatment and prevention clinic that I run out of the AIDS network in Hamilton. And the second is a Peter Boris Center funded study of unmet mental health needs of patients at the Good Shepherd Transitional Beds program that Leslie had mentioned earlier on in the talk. Next slide, please. So the HIV treatment and prevention clinic is a clinic that I've been running for the last 2.5 years now, or maybe a little bit longer. That's co-located at the AIDS network of Hamilton, which is just downtown in the Effort Trust building at the corner of Catherine and Main Streets. It was started as a clinic that was meant to be low or no barrier, which is one of the reasons why we co-located it with the AIDS network. The AIDS network is a place where people from the population that we're trying to serve feel comfortable going to. We're already using services there, felt kind of welcome and again comfortable, as opposed to some of the more traditional medical settings where they often feel like they're not welcome or that they shouldn't be there. The idea was to offer both a drop-in just for general infectious disease issues related to substance use disorders, as well as for co-treatment of HIV infection for patients who were poorly served by the traditional medical system, and for their opioid use disorder as well. And the idea from the start was that we would have strong community leadership of the clinic model. So we have peer support workers and patients informing our model and helping us to make sure that we're offering a service that is appropriate. Currently, in terms of the HIV treatment piece, we have 12 HIV positive patients enrolled in the clinic. And OHTN again offered some funding just to track our outcomes with these patients in particular. And after 1 year of follow-up with them, we've been able to maintain all of those patients in care. We haven't lost any patients to follow up at this point. And as of current data, looking back to February of this year, 75% of them have fully suppressed viral loads. I apologize if you're catching noise of my new puppy who's making barking noises in the background. Next slide, please. Some of the lessons learned early on. So our final data analysis for this will happen in August of this year, but some of the stuff that's come out of this is, again, the importance of peer support work. So one of the main things with the population that we're serving at the AIDS network is a clear lack of trust with the traditional medical system. And so we use a very strong peer-led model where we have peer support workers in clinic every week, as well as doing outreach into the community to make sure that people know that they can trust us. So we sort of use the trust that they have with that peer support worker who's built up a kind of a well of goodwill and trust in the community. So having them vouch for us that we are going to look after them well and offer them good care offers a bit of a bridge for them to come in and to continue to follow with us. The importance of a welcoming environment. So again, this was sort of part of the design of the clinic, making sure that people felt welcome into the clinic space. So there's a number of different things there. Partly it's locating it in a place that they already trust. It also means that it's a very sort of loosely organized clinic. We don't really have appointment times. It is drop-in. People can spend as much time in the clinic environment as they want. In the winter months, we find that people do spend quite a bit more time because it gets them out of the cold. We offer a hot lunch every day. So when patients come after they see me, they can grab a hot lunch that they can eat either in the clinic space or outside. We've got our peer support worker who can sit with them for half an hour if they want and just sort of talk over things. And so it's again just meant to be a place where people feel happy to come rather than kind of a burden to come to the medical appointments. And then again, one of the main things again was that very early on, it was clear that one of the things that I was not an expert in offering was mental health care. And so I would say 100% of my patients in this clinic have either undertreated or underdiagnosed mental health issues. And so that was something that I struggled with in terms of what to offer them for help with that. And now we have, again, through the kindness of somebody's willing to volunteer in the clinic, there's a psychiatrist that's there every week that can sit and talk with people and offer some mental health care as well. So again, this was part of the model of just making sure that we spoke to our patients, found out what their needs were, and then actually responded to them to continue to improve the clinic. Next slide, please. The next study, which is really just getting off the ground now, but just to mention it because again, it aligns with what we're talking about this morning, is a study based out of the Transitional Beds program. We've talked about the Transition Beds program before in Grand Rounds, but just quickly to review again, it is a 10 beds facility that's run out of the Good Shepherd Men's Center on Mary Street downtown, that is meant to provide care to people who are experiencing homelessness or precarious housing who have ongoing complex medical needs. Next slide, please. So it's the Good Shepherd Men's Center is a shelter space that offers nightly shelter for men on the first floor, and then the Transition Beds program is located up on the third floor. As I said, 10 beds. It was meant to be co-ed, but in practicality, it's served a male population, mostly because we found that it tends to be a bit of an uncomfortable place for people who identify as women to be. And so it's been predominantly men who have accessed the facility. It does operate within a harm reduction framework. So there's patient education, safe use and supplies provided. There's not a safe use space on site, so patients still have to leave the facility to use drugs if they choose to. Referrals are generated primarily from the hospital. So the idea is that it is a transition from hospital to home. And again, the idea with that is that patients aren't discharged from the transition beds to shelter, but are actually found stable housing. Next slide, please. So this study was sort of a pragmatic study that came out of an identification of the staff at the Good Shepherd, who found that patients who ended up there generally would stay for 6 weeks, sometimes longer. And what the staff found was that they would slowly, over those couple of weeks, start to open up to staff about many things in their life, including past trauma, ongoing mental health concerns, and that as they became more comfortable and trusting with the staff, a lot of this would sort of come out naturally and organically. The staff, however, didn't, again, have the training beyond just being a sympathetic and listening ear to actually intervene or to provide any expert care for their mental health concerns. As well, as we've all experienced, sometimes getting access to the mental health system is difficult, and particularly for the patients accessing the Transition Beds program, finding their way into see a mental health professional was challenging. And so we ended up speaking with the Peter Boris Center, who kindly provided funding and some research expertise to help us design a questionnaire-based study just to document the unmet mental health needs at the Transition Beds program, with the goal of then using that information to design an intervention project. Next slide, please. So at this point, the staff at the Transition Beds program have been trained on how to administer the questionnaire. The questionnaire has been developed and we've gone through REB. Partly this project has been a victim of the chaos of COVID. And so the Transition Beds program has certainly not been spared any of that. There's been outbreaks there. There's been a fair degree of staff turnover as well. That has really limited our ability to get this up and going. But at this point, we're starting to do enrollment and hope to have results in the near future. And that's the end for me. So I think now we go back to Dr. MacKillop.
Thanks, Tim and Leslie. Those were great presentations. I just want to offer a few thoughts before we're happy to answer some questions. I think that the common DNA across all these projects is the idea that there's a great deal to be gained from highly patient-centric and lived experience informed research projects that really kind of meet patients where they are. These sorts of projects can be very revealing of a lot of intuitions and hunches we have that then convert those hunches into black and white data. So, you know, what is emerging across a lot of different programs is that whether they are designated substance use disorder programs or medical programs, the reality is many services are de facto mental health programs, de facto traumatic brain injury programs. Because there are very high rates of comorbid psychiatric issues and head injury. And although those aren't the reasons people are coming for care, those are part of the reasons that they may ultimately not have an optimal outcome. And I think that these projects offer examples of how you can shine a very powerful light on the services that are delivered, and then also how those data can be thought of as a way to advocate for changes in service, because hunches and intuitions are rarely as convincing as black and white data that simply document the rate of depression or anxiety or PTSD or head injury that suggest that there's a real need for additional resources to support these kinds of indications. So I think that there are both kind of internally looking and externally looking benefits of thinking about these integrative clinical research projects. And I think that the last thought is that I have is really how this fits into a larger framework for clinical research on substance use disorders and other conditions in which the conventional research designs and practices of evidence-based medicine, which intentionally and to their credit, emphasize internal validity, rigor, and design features can be married or at least complemented by what we can think of as practice-based evidence, the evidence that we can gather from real-world care in often heterogeneous, complex, and challenging populations that, for better or worse, constitute typically the majority of patients who are out there. So in many ways, we need the majority of patients to be represented in the research that's happening, not a minority of less complicated or less complex patients. So this is not to say that these sorts of initiatives should be intended to replace traditional designs, but rather to argue that we need to have a big tent when it comes to thinking about research in substance use disorders and embrace both conventional controlled research, but also real world integrative patient-centered research. And I'll stop there, and I think we'd be happy to answer any questions people might have.
Thanks, guys. That was excellent, as always. Greg's asked a question in the chat box, which I think I'll state and then I'll expand it a little bit. So Greg Kernu asks, can you recommend any resources about how patients, and I'll add, and physicians can learn more about these problems, particularly when they're inpatients? So what resources are available to help physicians and patients better understand these disorders? And is there a way of leveraging some of the technology stuff that we have access to facilitate that?
So I can speak to the patient side of things in terms of resources that exist. And one of the strategies that we've started recently, the Canadian Centre on Substance Use and Addiction does have a lot of high quality KT products in terms of providing information about substance use disorders that can be used as resources for patients. But the other thing that's increasingly happening is we're developing handouts from patients' own information to give them feedback on the profiles that they're providing and get their, well, basically to elicit their reactions to the profile that they're reporting to see if that can be used to shape their care. So I think that there can be direct patient feedback loops. I'll leave it to Leslie and Tim to speak to the physician side of things.
I guess I would highlight some of the work that Anthony Levinson has done with MacHealth. There's lots of great resources and clinical primers available on the MacHealth website, and it's locally grown, which is fantastic. Another resource that has really great resources for both patients with substance use disorder as well as physicians is the Medify website, which is through Women's College in Toronto. So those would be two that I would just, highlight. I think there's lots out there, and sometimes it can be almost overwhelming to sift through some of it. And I do know many of the patients that we see are on there kind of Googling, finding all sorts of different resources, but then we have others that are a bit less tech savvy, and these resources would not be as helpful for. I don't know, Tim, if there's any other resources you want to highlight.
Yeah, I mean, I think I would just highlight again the addictions medicine service, and I think that's one of our roles. And so making sure to involve us for phone advice or to do formal consults if you have questions about how best to help a patient. I think that's one of the reasons that we're there. And then as well, particularly at St. Joe's, the capacity building team is a very helpful resource, both for the patient and for the medical staff, including the allied health staff, in terms of how best to help an individual patient, how to kind of manage the cravings and withdrawal piece and some of that stuff. And so making sure to involve them early and often in the patient's care.
Strikes me, I apologize, I should know this. Is there a continuing health sciences education or CHSE day in addictions medicine? And or if there is, how do we build the profile of that? And if there isn't, should we put one on?
So currently, I don't believe that there is one. Prior to COVID, we used to put on a half day on addiction for the undergraduate medical program, and it was very well attended. Robin Lennox was one of our speakers one year describing the inpatient addiction medicine service. My sense is that there's a very high demand for education and that this doesn't exist in the traditional curricula. So certainly there may well be appetite. Leslie and Tim, could you speak to that?
I know it's something Nishma Singhal and I have spoken about, but I think it got a little derailed as well with COVID. So yeah, I'd certainly be happy to regroup with her about that.
I think that would be a great resource. Ann Holbrook asked, you can see her question there, but marrying complex patients with rigorous research to me means pragmatic randomized trials. Are these going on in addictions community? I guess that then begs the question, are there interventions that are ready for being used in a randomized controlled trial? Or are we still in the fact-finding part of understanding this disease?
I think from my side of things, for opioid use disorder in particular, there's definitely some randomized trials that have been done. And I think the best evidence we have is still for methadone and Suboxone for sure. There's other excellent trials, particularly out of Vancouver in Canada, on injectable hydromorphone and injectable heroin as treatments for refractory opioid use disorder. So randomized trials certainly do happen. My experience, difficult to do sometimes. And so one of the things that we were looking at was doing some evaluation around safer supply, which is a newer paradigm in opioid use disorder, and providing dilaudid tablets for patients, again, who are refractory to other types of treatment for opioid use disorder. And getting ethics approval for off-label use for things like that, obviously, is quite difficult. So I would say yes, they are being done, but can be somewhat difficult and resource intensive, I think, to organize.
I would just add to that to say that there is a large field of controlled clinical research on substance use disorders, as Tim alludes to, in terms of opioid use disorder, but also alcohol use disorder and tobacco use disorder have large evidence bases demonstrating pharmacological and behavioral interventions to be effective. They do tend to be on patients who are less complex than are typically seen. But also many substance use disorders don't have established medication-based strategies. So stimulant use disorder and cannabis use disorder have no Health Canada approved medications. There are behavioral interventions that have been shown to be effective. In particular, motivational interviewing has been shown to be quite helpful in both cases, as has psychosocial support strategies like the community reinforcement approach. So there is an evidence-based literature, but often there's a gap between the patients who are in those trials relative to the patients who you might see in day-to-day care.
Thank you. The most common attendee at rounds is Anonymous. I don't know who Dr. Anonymous is, but I've turned Dr. Anonymous off. I keep forgetting to do that. This is actually a really interesting question, and we only have a few minutes, James. What's the neurophysiologic basis of cravings, and I guess underneath that, of addictions in general, and can those neural pathways be interrupted?
Great question. So, I mean, I think that this is a big area of debate within the field. Is addiction a brain disease? Is it a behavioral disease? Is it an environmental disease? And the very brief description of the brain disease model is that, unfortunately, by virtue of persistent heavy use of these psychoactive drugs, neuroadaptations do take place in the brain that basically co-opt our learning circuits and lead to ultimately not only physical dependence, but also cravings and the lack of alternative reinforcers. And so there's a very established literature on the biological basis for addiction. But the other side of the coin is that we also know that environmental factors are hugely important. And those range from risks from, for example, early life stress and adversity, to the reality that there are the major competing factors are often missing in patients with substance use disorders, as far as secure housing, food security, stable employment, and all the things that are naturally the counterweights to using substances. So there is a clear and deep understanding of the biological basis for addiction, but that is complemented by an equally large literature showing that the environment and the psychosocial world is very powerful as a both cause of developing addiction and as part of recovery. And I think that those two sides of the coin have to be considered together. I don't know if Leslie and Tim, you would add to that.
Oh, I think you got it. Thank you.
I think the underlying science, James, is your area of core competency. Greg asked two more questions. So the first is, can you send a list of resources? Tim, could I ask you maybe just to type together like one page with 5 lines on it that just give the list of resources that you guys discussed, and I'll put it into the Friday update in an upcoming week, just so that people have access to that. And then secondarily, this is again probably a question for James for the science, and then more broadly for the impact between Leslie and Tim. How does cannabis enter into the equation? I know that, James, that's an area of research interest for you, and we've talked about it. It's very interesting.
Yeah, I think it's a hugely important question, because cannabis nowadays is often the most commonly used substance we see, and the most commonly identified primary drug in a number of the clinical settings we do research in, for example, concurrent disorders or at Homewood. And I think that unfortunately there are a lot of myths around cannabis, that because it's been legalized, it's doesn't have risks, that because it is often consumed as a plant, it's more natural and more healthy, because it doesn't have a high toxicity risk in terms of overdose. It's also benign. The reality is that cannabis use disorder is a real condition. It seems to be more severe nowadays because of the availability of very high potency products. And high potency products mean people become dependent on higher levels of THC, and as a result have more significant withdrawal symptoms. There are no great treatments for withdrawal, unfortunately. And another myth is that withdrawal from cannabis isn't a real syndrome, although that, at least within the field, has been dispelled for a long time. So unfortunately, there's a lot of misinformation and misunderstanding about the significance of cannabis use disorder as a syndrome, and its very high comorbidity with anxiety, depression, and PTSD. And as a result, I think a lot of patients feel like they have a somehow less than legitimate substance use disorder, when in fact it warrants care just like any substance use disorder. So we're doing a lot of research on the changes that are following legalization and novel strategies for addressing cannabis use disorder, because as I alluded to, there are also no medication-based strategies that have been approved at this point. And just as a kind of clinical note, across patients, we see that typically the lowest levels of confidence and importance for changing cannabis use behavior are in individuals with cannabis use disorder compared to opioid use disorder, stimulant use disorder, and alcohol use disorder. So even patients themselves are much more ambivalent about changing that behavior, which is itself a problem. Leslie and Tim, what are your thoughts?
Yeah, I mean, so we are measuring this in our inpatient data set, and I'm very curious to see. I would say in general, because we're often dealing with such a severe opioid use disorder patient population, that similarly, if they do have concurrent cannabis use disorder, they are very ambivalent about it. And as the treatment team, we are focusing on the highest risk substance use at that point, which would be, for example, injected fentanyl. And so we do often prioritize our intervention around the substance that is most problematic and kind of allow the patient to prioritize alongside with us. That cannabis use might not be the number one thing that they're targeting to change at that moment. So it'll be interesting to see how it plays out in our data measurement as well, with more patient populations captured. But I mean, I agree otherwise with everything that you said.
Last question. We've got about 2 minutes left. I think anybody want to take this one on from Dr. Sarah Patterson? Any suggestions for managing Dr. Iatros and his predilection to cause opioid use disorder? Some comments there about chronic pain, but I think a general question is this something the addictions medicine team can help with, or are there tools or suggestions to, I guess, probably more importantly, avoid putting patients in the position where they develop this, and then if they do, helping both the patient and ultimately the physician who got them there, and thoughts about this?
I can tackle this maybe for 30 seconds and I'll let Tim. Certainly our service cannot meet the need of all chronic pain populations, and certainly anybody with chronic pain that has been on longstanding opioids will develop tolerance and will develop withdrawal. So we're always around to kind of field questions, but it's not a patient population that we're able to see systematically because we really flood our service. And as well, sometimes there's unintended consequences of the addiction service getting involved in chronic pain patients, because then it gets transcribed through the chart that they have an opioid use disorder when in fact they have chronic pain and perhaps challenges around tapering their opioids. The number one thing I would just want to walk away from this conversation highlighting is that we really should not be suddenly discontinuing people's opioids, because it will precipitate withdrawal for them and often lead to them seeking opioids from alternate sources, which is a much higher risk situation. So my general approach, and really I'd be putting on my GIM, general internist hat in this response, would be working with the patient around their goals, and sometimes trying a rotation to help them get down on their morphine equivalents, and then a slow gradated taper, but involving them in that rather than enforcing it upon them. And also employing some techniques of motivational interviewing around like benefits and harms that they identify with for their opioid use. And also employing the supports of our chronic pain services if there's other like non-opioid alternatives that can be pursued, like injections, for example. Tim, do you have anything to add there?
Yeah, in the last 30 seconds, I'll just say, I'll echo what Leslie said. I think the key thing there really is that for patients with complex chronic pain, it's unlikely that we're going to fix that in the hospital, in a hospital stay, number one. And I think we should really think of it as a long-term outpatient issue almost, and it needs somebody who's going to take that on in a very kind of ongoing trust building relationship type of a way. So I think the avoidance of, okay, you came in and you're on all these opioids for chronic pain, I'm going to cut them right down to zero, is probably a very dangerous one. And it's more involving that outpatient prescriber in coming up with maybe a better and safer long-term plan. Sarah, from your perspective, talking about patients with sickle cell disease, obviously those patients have providers in the community that you can get in touch with, talk to, raise your concerns and have an ongoing conversation with, but then ultimately putting it back to that community provider to manage, I think, in the long term, with supports if they need them.
Realizing that community provider in many cases is Tim's wife. So just a little plug for the research program for chronic pain. There is a very large research program in Hamilton, which is recently received a ginormous grant to look at some of these issues. And if you have an interest in chronic pain management, I'd encourage you to do a little bit of exploration around McMaster's website and identify some of the resources that have become available as a result of that. So with that, it's just shortly after 9. I'd like to thank our speakers. Great rounds, critically important, a very common cause of hospitalization, and obviously, as was articulated very clearly here, an enormous cause of morbidity, both in hospitalized patients and in the general population, and something which has been impacted by COVID. So thanks, Tim, Leslie, and James. And we'll do grand rounds again in a month, and your regular hospital grand rounds will resume next week. Thank you, everybody, and have a great day. Talk to you later.